Good morning to you all.
Good morning, sir.
I'm going to talk to you briefly about clotting, coagulation. So, what are the various mechanisms when a person sustains injury? So, they will have to stop. Now, I may tell you, please no cross talking. I already told you, please don't talk. No cross talking. Stop it. Otherwise, I'm very serious about it. No talking. Bleeding stops because of certain mechanisms. What does the blood contain? It has got plasma, RBCs, white cells, and the platelets. And the platelets have a great role to play in stopping the bleeding. Then there are certain factors which are, in our blood, which are, these factors are proteins, and they are enumerated as Roman numerals. Factor 1, 2, 3, 4, 5, 7, 8, 9, 10, 11, 12, 13. These are the protein factors in our blood which stops bleeding. They are generally, when blood is in circulation, our blood does not coagulate, does not clot in a normal state of affairs. The coagulation, clotting of the blood is called for, so also the role of platelets when the patient has sustained injury and the bleeding stops itself in a normal person because of certain factors. Now let's see. First of all, I will discuss with you the role of platelets in primary hemostasis. I repeat, role of platelets in primary hemostasis. Platelets are the cells in our blood. The diameter of cells, they are spherical cells. The diameter of platelets is 2 to 4 micrometers. It is not nucleated, it is colorless, it has got granules in its cytoplasm, and it contains the platelets as a wall, and it has got a canalicular system. That means there are channels within the platelets, and when it contracts, when they are required or stimulated, so the granules secrete certain secretions, and on the cell surface of the platelets, there is a secretion of phospholipids when there is a bleeding. So platelets, the number of platelets I told you last time is how much? It is 1.50 lakhs to 4 lakhs, 400,000 per cubic meter. Is that right? So in case the platelets increase in number, or it may decrease in number, once it decreases in number, it can cause certain problems to us. And this is called thrombocytopenia. If the platelet count goes down, it is called thrombocytopenia. Is that right? And once there is a thrombocytopenia, the persons have the tendency to bleed, the bleeding time will be prolonged. Is that right? So platelets act in 3 fashions. How they act? Number 1, it has got a quality of adhering when there is a bleeding, when there is an injury, the platelets aggregate together and they adhere to each other and to the damaged tissue also, right? Where the tissue is damaged. And it alters its shape and it sends out, pseudopodia like projections. So it helps in, it has got a protein within it which is called actin and myosin. And it can contract when blood is there. There is a platelet plug when the lot of platelets, numerous platelets adhere together, and once there is an injury, the platelets interact with the extracellular matrix in the vessel wall. So once the endothelium is compromised because of injury, the platelets start adhering to that place, and in subendothelial matrix, the platelets stimulate that, and it starts forming adhesions, right? And there is a plug. This plug is not a very firm plug, but at least bleeding stops in minor injuries. So the phospholipids are secreted, and these phospholipids secreted by the cell wall of the platelets form the platelet factor 3, which is helpful to us in the intrinsic factor, which is involved in the clotting mechanism. Is that right? So ultimate object, what happens is that the blood has got fibrinogen, which is a protein, which is in a soluble form. Fibrinogen in the blood is in a soluble form. And this fibrinogen is converted into fibrin at the site of injury. The fibrinogen is converted into fibrin, and fibrin is a kind of a mesh network. There are so many projections, and it is growing irregularly. Fibrinogen is converted into fibrin, which is something like a gel, and is insoluble. So therefore, with the site of injury, these are thread-like structures, a kind of a network, and they start adhering to each other and to the damaged endothelial wall also. And this fibrin network then is attracting the formed cells, including RBCs, white blood cells, and the platelets also, and the whole thing is then called a clot, right? It makes a plug, and then it contracts because platelets have got proteins, filaments inside, which is called actin and myosin. It contracts, and due to a contraction of the platelets, whatever the coagulum has been formed there, it expresses out the fluid out of that, and it shrinks in size. Is that right? So this is the mechanism of role of platelets in stopping bleeding, is by coming in contact with the extracellular matrix in subendothelial tissue, attracting platelets. They get adhered to each other, they are sticky, and they secrete, the wall secretes phospholipids, which is all, and then platelet factor 3, which is involved in the intrinsic factor for synthesis of prothrombin activators. So the basic phenomena which involves in further, the platelet plug is not a very strong one, but in case there is a major injury, then the other factors come into play. That is the clotting factors, right? Which I have mentioned here in Roman numericals: factor 1, factor 2, factor 3, factor 4, factor 5. There is no factor 6. Factor 7, factor 8, factor 9, factor 10, factor 11, factor 12, and factor 13. These factors are lying inactive in the blood. And once there is an injury, what happens is, at the site of injury, the tissues form the tissue factor, tissue thromboplastin, which is a factor 3, right? So what happens now is that these factors, which are lying in an inactive state, they become active, and they start activating other factors also. As a whole, when all these factors are involved together, the two pathways are there. That one is for making. The ultimate objective is to form the prothrombin activator. Right? The prothrombin activator, which is a very important part, plays important part in the clotting of the blood. When there is injury, there is a clot. You have seen many of us, sustain injury, and then blood stops itself. It may stop itself by this thing, what you call the primary hemostasis, or by secondary hemostasis, in which so many factors are involved. That is called clotting. Is that right? So this occurs because we need prothrombin activator. Prothrombin activator. The prothrombin activator is stimulated, comes into action after the vessel wall is injured. And this prothrombin activator helps conversion of prothrombin into thrombin. Prothrombin into thrombin. And thrombin again facilitates conversion of fibrinogen into fibrin. And you have already understood, I have already told you. So there's so many factors are involved. And in this mechanism, the intrinsic factor, one of the factors involved is factor A, right? And we require so many things in it. We require calcium also, and once a factor is activated, we add a suffix to it, A. If factor 7 is activated, factor 8 is activated, then it's called factor 7A or 8A. Alright. So basically what I want to tell you that the clotting of the blood occurs because of these protein factors in our blood which are activated by one after the other. And intrinsic factor, it is the factor 12 mainly which is involved. Is that right? Factor 12 is involved. So there are certain deficiency disorders, because the deficiency of these factors may result in certain kind of diseases. And what are those diseases? The prominent disease because of the factor 8 deficiency. There is a factor 8 which gets converted into factor 8A. So if there is a deficiency of factor 8, this is a factor which is an anti-hemophilic factor, which get converted into a factor 8A. If there is a deficiency of say factor 8, so this is an anti-hemophilic, so the person will have a disease which is called hemophilia. The hemophilia is transferred from generation to generation. In which gender?
Males.
No, it is inherited by females, but the victims are the males. The classical example, what happens in hemophilia? Hemophilia is the disease because of deficiency of factor 8. And vitamin K also helps in synthesis of these certain factors. So deficiency of factor 8 might result in hemophilia, and it is transmitted from generation to generation. Females have that deficiency, but male child is affected. And this comes into picture only when the boy is playing, he has sustained injury or he is given injection. The bleeding does not stop. There is no clotting. Platelet counts in deficiency of factor 8, platelets may be normal. You get my point? So when we investigate these patients with deficiency of factor 8, the bleeding time is normal. Why? Because platelet count is normal. There is no deficiency of platelets. You get my point? The bleeding time in deficiency of factor 8, hemophilia, is normal, right? But clotting time is increased. So let us see what is the normal bleeding time. Bleeding time, it is 2 to 6 minutes. You can test it. Bleeding time, I mentioned here, bleeding time. When you inflict some injury to the lobule of the ear or the fingertip, distal phalanx, this is the distal phalanx, palmar aspect, okay? You put a prick there, or you injure, or small incision may be given. This is too much. It's a little more invasive. So bleeding should stop within 2 to 6 minutes. But in case there is deficiency of platelets, there is a thrombocytopenia, the bleeding time will increase. It will go beyond 6 minutes, but clotting time is normal. You get it? A person, now what are the diseases? Now platelets goes down sometime in a dengue fever. Classical example in our setting is dengue. Patient has got fever, headache, body aches, this is a viral infection, and platelet count may come down. So I've seen the patients whose platelet count has come down to 25,000 or so, even in 12,000, and therefore they have a tendency to bleed. They bleed from the gums, injection is given, they start bleeding, right? So thereafter, it's just I'm digressing a little bit, we have to treat them symptomatically, plus we have to give them fresh platelet transfusion. Platelet transfusion. And don't give a platelet which is older. The shelf life of platelet is very less. It is, about barely 7 to 8 days, not more than that. The life of platelets, it is one of the components of the blood, From 1 unit of whole blood, you can have so many fractions, so many things. So it can be utilized for so many patients, right? So platelet transfusion is given when the platelet count comes down, and may come down, in certain people who are having chemotherapy or hematological malignancy. So if the count comes down to say 25,000, so patient starts bleeding, he has to be given platelet transfusion. Coming back to clotting. When a person has got hemophilia, the classical example of a famous personality who had hemophilia, he started this is son of, his name was Alexei, son of Russia's emperor, last emperor, Tsar. So this boy used to get hurt, injured, and they found that he starts bleeding. So the classical example of hemophilia, right? And in those days there was no treatment also. So in hemophilia, the clotting time will be prolonged, and clotting time is how much? It is 6 to 12 minutes. The clotting time is 6 to 12 minutes in hemophilia, but in hemophilic patients, bleeding time is normal. Bleeding time means when you have inflicted a small injury to a person, the moment after an injury the bleeding stops, that is called the bleeding time. What is the bleeding time? Bleeding time is when you given a pin prick. Bleeding should stop within 2 to 6 minutes. So that means after you have inflicted a minor injury to the patient, and till the time the bleeding does not stop, and till the time when the bleeding stops, that is the bleeding time. You get my point? And clotting time is when you draw the venous plug of a patient and you put it in a test tube at 37 degrees centigrade, and after you have withdrawn, and when it has started clotting, it has become a clot, that is called the clotting time. Is that clear to you? So bleeding time is the time after the pin prick till the bleeding stops, and clotting time is the time after the withdrawal of the venous blood at 37 degrees. When you store it 37 degrees, when it becomes a clot, it is called the clotting time. So again I repeat, bleeding time is 2 to 6 minutes and clotting time is
6 to 12 minutes.
6 to 12 minutes, right? Now, one problem with deficiency of factor 8 is hemophilia. But there is another disease in which patient starts bleeding, and that is, anybody? Purpura. What is that? Purpura. P-U-R-P-U-R. Purpura, I must have mentioned somewhere here. Have I?
Yes, sir.
Okay. Purpura, it is here. Purpura is due to, you see a patient, he has come to you. In hemophilia, when a person sustains injury, he falls, there is an accident, and he undergoes dental extraction. He undergoes dental extraction, bleeding doesn't stop. It doesn't stop for weeks together. So that means one should suspect that he has got what? Please kindly focus, look at me and listen to my words. If a person falls and sustains injury, open wound, or he has undergone dental extraction, the bleeding doesn't stop for a week or so. So that means likely he is having hemophilia, deficiency of factor VIII. Another disease is purpura. Purpura is because of thrombocytopenia, because there is a deficiency of platelets. The count is much lower than a normal count. And once there is a bleed, maybe spontaneous bleeding is with a severe thrombocytopenia, the patient starts bleeding, and there are multiple pinhead size, numerous red spots, bleeding from the capillaries. Okay? This is called petechial hemorrhages. These are called petechial hemorrhages. P-E-T-E-C-H-I-A-L. P-E-T-E-C-H-I-A-L. What did I say? What did I say? P-E-T-E-C-H-I-A-L. Petechial hemorrhages. P-E-T-E-C-H-I-A-L. Petechial hemorrhages. There are multiple splinter hemorrhages. Jagah mein we will find red spots everywhere, over the skin and under the nails also. Is that right? This is called purpura. The disease is called purpura. Right? So, the count of platelets has come down. Now let's go into the next thing. I want to tell you what kind of investigation we should do in these patients' investigations. Let me tell you, as a person, as a trained person, you are involved, you are very specific to do a job, that is the patient care. So therefore, we cannot confine ourselves to focused investigation, ki bas ye karwa liya, 1, 2, 3 and that's all. Because it involves one investigation, activates one to conduct another investigation, order another investigation. Okay? So this is a kind of a composite idea. In your mind, you take history, clinical examination, and you formulate the possibilities, which is called provisional diagnosis. And what all possibilities are there, which is called differential diagnosis. So whatever comes to your mind, whatever you think, this comes by your knowledge and experience. What all investigation should be conducted. You cannot leave any investigation which is relevant you have not done, because you will be hauled in the court. Nobody spares doctors as far as negligence is concerned. The judges are going to ask you, sir, they are very learned people. They'll ask, did you do the CT scan or not in this patient? So I said, he had just made backache, so I didn't think it's, no, we'll call another fellow. Can he have pain due to metastasis? He said, yes. You should have excluded. So thereafter, what I will see in bleeding disorders, what are the main investigations? One is the complete blood count. First, you start with the complete blood count. In complete blood count, what are the investigations you do? This gives you generally, one is the hemoglobin. What are the percentage of hemoglobin in the blood? Normal is, amongst females should be about 13 grams %, and among males it should be right from 14 to 18 grams %. Hemoglobin. Then the RBC count, red blood cell count. Then to find what is the volume red cell, MCV volume. Then there is MCL, mean concentration, mean hemoglobin concentration, MHC, MHC, mean hemoglobin concentration. And in that you'll find so many other things, including platelets also, right? So this gives you a brief idea, and we conduct an investigation which is called ESR, erythrocyte sedimentation rate. This is increased in some kind of way. That means there is some problem, some chronic disease, right? Then in the same investigation, you should ask for BP and CT as a matter of convention also. And a person, why? What is the importance? The importance is that if you do not conduct full investigations on a patient, blood investigation on a patient who's to undergo surgery, then you realize, sometimes what we do is there's a very small nail, we have to extract a small lipoma, it won't bleed and things like that. What is the requirement of the investigation? But God forbid, in case there is a person has a tendency to bleed, his BTCT is not normal, then we had it. 7 days he goes for surgery, you're given incision, now the bleeding won't stop. So therefore you have to be on safer side. You must keep yourself safe by conducting all the investigation, even if it may not be required, but then it may be helpful, right? So BTCT must be done. And second investigation which we consider is not of much use, that is differential leukocyte count. You heard about a DLC? We draw the blood and make a smear, then it is stained, and then we see it in under the microscope. Then what does it tell us? It will give us a picture. Now if you do CBC, cannot tell you what is the shape of the RBC. It will just tell you what is the hemoglobin, what is the RBC count, what is the diameter of RBC, how much is the autoanalysis I'm talking about. It will tell you about MHC, etc., or MCV, etc., right? But it cannot tell you what is the shape of RBCs. RBCs may be deformed. There may be certain bodies, there's no bodies inside the RBC except hemoglobin and things like that, right? But there may be, there's a RBC, there's Howell jaw, this is called Howell jolly bodies, Howell-Jolly, jolly. So you make a sphere and you find very dense rounded picture inside the RBCs. The RBCs may be deformed in macrocytic anemia, megaloblastic anemia. The shape may be different, anisocytosis, polygyrocytosis, and things like that. The shape you can find only when you are making a smear. Are you understanding what I am saying? You have given a prick, you have put that drop of blood on the slide and made a smear, and then get it stained, a Leishman stain or whatever it is. There are names of the stain. And then there you see the shape of the cells. And what else we see in this smear is white blood cell count. White blood cell count you make only from analysis, right? But earlier there was a chamber which used called a Newbar chamber, and you used to fiddle around and count various RBCs in one particular square. So you will come to know that only when you are doing differential leukocyte count. Tell me how much is the percentage of neutrophils in this thing smear. What should be the ideal number?
50 to 70%.
50 to 70% are neutrophils. Neutrophils are multinucleated cells, part of the white blood cells, right? The count is 4,000 to 11,000 microliters, right? Then comes your lymphocytes. Lymphocytes. What is the count? What is the percentage? 20 to 40%, right. Lymphocytes have large nucleus, they are rounded cells, and you can't distinguish which is a T lymphocyte and D lymphocytes. Where are T lymphocytes involved? I told you that. What is the basic philosophy behind T lymphocytes? And what is the role of thymus gland with the T lymphocytes? You have a thymus here, thymus gland, right? In the mediastinum, in the chest. And as we grow up, this atrophies. So T lymphocytes are mature in children, in the infants, and the thymus gland is involved. And we have got B lymphocytes also. So T cells give us cell-mediated immunity. Didn't I tell you this before? I told you. Okay? And B lymphocytes, they are basically involved in humoral immunity and globulins come out of, they are proteins. So lymphocytes are T lymphocytes are involved in that. Is that right? Then next cell is eosinophil. Eosinophils, where these are increased? Neutrophils are increased in which condition? You tell me. When the count of neutrophils goes up, or the white blood cells, okay, goes up. If the white blood cell count goes up more than 11,000, 12,000, 13,000, 15,000, today's the revision also, and going back also. Sit down. Anybody who can tell me if the count of white blood cells goes up? I'm talking to you about investigation. What all investigation we have to do? It is just a digression and diversion from that, which is, I told you, you cannot confine and localize yourself to one localized vision. You have to go out also. Your horizon has to be broadened, because when you're discussing one thing, you have to, what is linked, you have to, your area of knowledge and your intelligence and this thing, what you call that, vision should involve other things also. So tell me, what happens? Anybody who can tell me in what condition white blood cell count goes up? Just 2 or 3.
Infection.
Okay.
So during viral or bacterial infections?
In bacterial infections, the white blood cell count goes up. In case there is a pus somewhere in the body, in case the boy is having acute tonsillitis, for that matter, any gender, listen down. If the white blood cell count goes up, that means there may be infection somewhere. He says that I've got a fever, I've got pain, at this there is a redness, there is a swelling. That means person has got infection. So what happens? It's something like the army troops who are coming because he has got invasion by a microorganism, a bacteria. So white cells come out in large numbers and their number increases. Their life is very short. They do sacrifice for our body. Barely they last for few hours, and there are thousands and thousands and thousands of cells coming around and taking over. They're fighting it out. The fighting virtually with the antigen, the bacteria which has come. They target it, they engulf it, and they just destroy it. And what is the method of destruction? By white cells? Phagocytosis. One is they target the antigen, that engulf it, surround it with a pseudopodia projection, and then the whole bacteria comes inside, white blood cells, neutrophils, and let's see neutrophil. And what happens is, the proteolytic enzyme inside, lysosomes, they destroy that damn thing and it is then thrown out of it, which is cleared by, who's going to clear that? Once the bacteria is destroyed, somebody has to clear it. So the monocytes, now monocytes also come out of that side. Within the lumen, they don't stay. They cross their boundary, go to the other country, outside in extracellular space, wherever there is an infection, and if it is within circulation also, say macrophages clear it. They live for quite long. But neutrophils die in minutes, you can say. And it becomes part of the pus. Pus is the dead tissue, pus is the white blood cells. Okay? So that is what they are doing. Okay. And white blood cell count may also increase in malignancy. There's a bone marrow involved. After all these cells come out from where?
Red bone.
Bone marrow. There is a single stem cell out of which there is a proliferation and differentiation into various type of cells. Is that clear? Now I was talking to you about what is the next class? No class. Have we class? Have we? Then I'll cut it short. Is it 1 hour over? No.
No, sir.
Okay. All right. Let's continue. Eosinophils. The eosinophils are 1 to 4%. This slide, when you're taking, you can see the eosinophils. The nuclei, the two nuclei are spectacle shaped, right? Eosinophil count will be increasing beyond 4% if a person has got allergic condition or he or she is suffering from parasitic infection. Is that clear? So then they are basophil 1%, somewhere around basophil. And monocytes I am talking about is 2 to 8%. Their size increases so much so in infection that it may become somewhere from 10 to 14 micrometers to 80 micrometers. Is that clear? And they are one single monocyte able macrophage is capable of killing 300 bacteria, 200 bacteria, 150 to 200, whereas single neutrophil can kill only 20 to 30 bacteria, right? So next investigation is, I told you that we do CBC, that is complete blood count, or FBC, a full blood count. It will give you an idea, you see that, when you say that a patient is having anemia or infection, or TLC count is, white blood cell count is less, or it may go into lakhs, or in a differential leukocyte count, you will get an idea what is the percentage of these white cells, right? And you might see some abnormal cells in the smears in the slide. You might see some blast cells, you may see myelocytes there. So it will tell you that the person may be having a hematological malignancy like acute myeloid leukemia or lymphatic leukemia. This is a blood-borne malignancies. Another thing in such situation is we do the bone marrow examination. Bone marrow. How do you examine? You do bone marrow aspiration. And there are needles for bone marrow aspiration. Bone marrow aspiration and cytology and the culture also. Culture means that you send the tissue to the lab to see, exclude any organism is there. Is there any infection or not? Okay? So you will send this bone marrow aspirate. You push the bone marrow fluid if you want to have, contents you want to have, you have to put a needle. There is a special needle for this. And this is the iliac crest. Where is the iliac crest? Iliac crest is posterior part of the iliac crest. You give a local anesthesia, put a bone marrow aspiration needle inside and aspirate the contents. And there is another condition which is called biopsy. Biopsy also you can do. This is called trifine biopsy. A very limited amount of core of the needle goes inside and the tissue is taken out. Bone is taken out. Bone marrow is taken out. And then it is decalcified. It is decalcified and then it is stained also. And sections are made to see histopathological diagnosis. What is the problem with the bone? That's right. So bone marrow examination is very important. Now besides that, it will give you an idea when. Now I am digressing from this discussion. Whenever a patient will come to you, we generally order those investigations which are relevant and specific. You understand? Relevant. If a person has got a swelling here, lipoma, so you can't send him for PET scan, suspecting it may be a tumor or like that. No, you cannot do that. So our judgment should be focused. At the same time, we can't afford to exclude certain investigations which may be directly related to the severity of the disease. This kind of a judgment you have to make. The decision which you do is far, far, far difficult and complicated for a doctor, surgeon, nursing staff and everything, that to order an investigation or not to order the particular investigation, but it is cost what matters. But if you go wrong, pain there are hundreds and thousands, hundreds of causes for pain. If you don't do the investigation, somebody will drag us to the court. I had gone to this thing, doctor was very casual. He didn't examine me properly and I was having pain and he said everything is all right. But ultimately they reach with, with a disease which was lying dormant. Person goes to a doctor with a constipation, so he writes down laxatives. Young person, so that he can have like some constipation. So he'll advise take more fluids, take laxatives, and things. It has happened, and ultimately somebody else examined. He examined the digital rectal examination. There was a growth, and by the time the patient underwent for further investigation, colonoscopy, CT, and PET scan, there's a stage 4 carcinoma, anorectal carcinoma, which is spread everywhere. So you have to give, now you can't, a person comes when a 25-year-old boy is got constipation, you cannot order, do the colonoscopy and do the CT and PET scan and things like that. So there should be, but generally, above 40 years, what we do is average for your health, that any person above 40, you can subject that patient to X-ray of the chest. It will give you a lot of information, your pulmonary status, the cardiac size also, right? And suddenly you may find a person is having hemoptysis. Hemoptysis, what is hemoptysis? It is the blood in the sputum, and you find there are secondaries in the lung. And patient is getting in cough syrup and antibiotics, thinks you'll be all right, and things like that. So X-ray chest above 40 years of age you should see. What I told you, complete blood count, right? Which includes TLC, DLC and all things like that, and DLC also. But above 40, you should do, particularly a person who's going to surgery, X-ray chest, ECG, right? And any woman coming to us whose age is more than 50 years, she should be subjected to mammography. What she should be subjected to? Mammography every year as a screening method. God knows who's having, you will detect out of this thing, 100 patients, 10% may have some kind of a swelling, may have a tumor. It may be lipoma only, but it can be malignancy also. Then, once we have this doubt of swelling in the breast, that there is a swelling, we do the ultrasound also to see whether the shape is regular or irregular. It is deep-seated, how many swellings are there that you have to do, and you have to do the mammography, final especially cytology and clinical examination. So remember, after 40 years, when a person is having any disorder, maybe bleeding disorder, he should be subjected to ECG, X-ray chest. What else? LFT, liver function test. KFT, kidney function test. Blood sugar. All persons above 40 years of age should be subjected to blood sugar, fasting and PP. Then there is a condition called HbA1c also. And normal urine examination. Is that all right? Okay, now I want to ask you a few questions. Who can tell me the structure of, because I have taken this topic, now this is the revision, what we talked in previous lectures. Tell me the anatomy of muscle cell, muscle fiber. Can anyone tell me what are the structure, histological structure of a muscle cell or the muscle fiber? It's the same thing. Who can tell me? Anyone? That means it shows. You see, this is perfectly all right. I was also a student like you. Even now, there are certain things we don't know. When we are in the class, we should be attentive to the teacher. And you should come to the class fully prepared to see the teacher, has he prepared his lecture or not, number one. Secondly, it will help you also. If you are prepared, you read what topics being taught to you. So, when you listen it from the teacher, you will never forget it. And thereafter, when you go back to your home, again read it. It will be a permanent impression. It will create a permanent impression in your mind. But if I ask you certain things which I've already told, that means it conveys 2 or 3 things. Number one, that you came to the class unprepared. You have not read it. And second thing, it also means that you attended the class, you are not attentive. You have been attentive. You see, all of you are looking at me, but mind is somewhere else. It's a fact. You're staring at me, and I also feel that you are staring at me, so that means I am drawing the full attention. But your mind is gone somewhere. A young people's mind is very fluctuating, and the mind is a very disturbing thing. It takes you to, it will show you everything. Picture भी बता देगा, जो खाना खाया वो भी बता देगा, कब खाना खाना है, उधर मन भटक रहा है. And what the teacher is talking is not there. You are not registering it. It is the case with everybody. So I asked you, tell me the structure of muscle cell. One single person fell. No. So that means you are not being attentive in the class. Muscle cell is a multinucleated cylindrical cell. Didn't I tell you? It is covered by cell wall which is called sarcolemma, and its cytoplasm is sarcoplasm. And what are the proteins in the muscle fiber? All the muscle, I am raising my finger. There's a impulse is gone and there is a contraction. What is, tell me what is depolarization, repolarization? Resting membrane potential. What is resting membrane potential of a muscle cell? Thank you very much. Okay.